Cadavers have been used to study the human anatomy for centuries. Today, first-year medical students learn from bodies that have been prepared using plastination or embalming to prevent decomposition. But some schools are beginning to wonder if this traditional teaching method is still the most effective. While cadavers offer an incredibly realistic view of the human body, Kristen Ramirez says it's not an exact replica of what students will see in the real world.
The process of preservation of the cadaver does change the look and the texture of these structures. Of course, there's no pulse in the arteries in the cadaver that there is in the real patient. So there are real tactile differences between a cadaveric dissection and an introductory anatomy course versus the practice of surgery.
Ramirez is a course instructor of anatomy at New York University Grossman School of Medicine. In 2019, NYU stopped using cadavers in their anatomy classes. Instead, they followed the current industry wave and turned to technology such as virtual reality.
We recognize that as our students are going to move forward to become physicians, even in surgery, which maybe you could argue is the most important need for a dissection-based experience prior, so many surgeries are turning to laparoscopic and other minimally invasive approaches. So by reducing the amount of time that our students are spending during anatomy dissecting, they're able to redirect their time towards learning, towards seeing the anatomy, not only in preparations of the body, which we still provide them with prosected cadavers as well as plastinated specimens, but then they're able to integrate radiology and other more applicable visualizations of the body into their anatomy education.
In addition to saving time, Ramirez says the shift away from cadavers allows students to better visualize parts of the body that are often overlooked during a dissection.
There are some spaces that are so small or so deep, you'll never be able to experience them in a dissection. So for us, VR was always about new visualizations, because the other resources that we brought in, these plastinated specimens, which are real dissected cadaveric, specimens that have then been preserved in a way that they will last forever, like turned into plastic, if you will, right? Plastinated. So they are still accurate, photorealistic representations of the body. They are derived from real donors. So any space that's too small and hard to see in a cadaveric dissection students were doing, it's also too hard to see if a faculty tries to dissect it, is also too small and hard to see in a plastination because it's all the same, right? It's all coming from donors. So VR is a way to take things that you really can't see on the body and blow them up, put them in different sizes and different orientations, and give students these unique views.
NYU has two unique VR experiences for students. During one, the student is shrunk down and placed inside the heart, able to roam around and gather a three-dimensional view of all the structures.
We've modeled red blood cells that are flowing to help them orient the direction of blood. We can label all of these structures, and the heart is a very geometrically complex space. And there's structures on all different sides. So when you're holding a heart in your hand, you have a little window cut into a wall, and you're trying to see what's behind these corners. It can be hard for students to understand.
VR allows students to put specific regions of the heart into context with what's around, since they're able to move through the structures themselves.
And that's the same for the second VR experience we have, which we shrink them down and we put them in what's called the pterygopalatine fossa, which many students previously had nicknamed the terrible palatine fossa, because it's very difficult to learn. It's very hard for students to grasp where it is, and it's small. It's smaller than a pea. So it's this tiny, tiny space, but it is the grand central station of the face, where all of these nerves and arteries that have to get into your nose, into your mouth, up into your eye, out to your cheek, back into where your brain is. And that was something that students were always very confused by. It was very complicated. That is something that is not really well shown on cadavers.
But using virtual reality allows students to better understand the patterns and branches of all the nerves and arteries connected in this tiny space. Aside from VR, students can look at 3D models of the body that are scanned from cadavers and manipulate them however they need.
They can rotate it, zoom in and zoom out. And we are also capable then of putting annotations on them. So our students can be standing in the lab. We provide them with an iPad that has the lab document on it, which has text and information, useful diagrams and images, but also embedded these 3D models. So they're standing in front of that specimen, which just looks like an isolated hand or half of a head or whatever the plastinated specimen is showing. And then in their hands, they have a digital version of that same specimen with all of those labels, and they can click them and see, oh, that spaghetti string is this nerve, and that tube is this artery.
The school has a few other 3D model integrations that all work to provide the students with the best understanding of how each part looks and functions. In addition to the added viewpoints, the digital renderings allow students to essentially take home their dissection.
Logistically, if you're a student, you can't take that cadaver home. So you have to be on site and able to be on site. Whereas many of the new resources that we've been able to provide for our students are digitized or have some sort of digital component to it. So our students can be studying on the weekend. And I mean, they do have 24-hour access to the lab, but practically for them to be able to access some of these resources from home or wherever else they may be in their studying is definitely a benefit that the cadaver does not allow for.
And they're able to take these tools with them into future classes and clinical practice. Ramirez says that, for the most part, students are happy with this new approach to anatomy. Any negative critiques are about technical difficulties working the programs or that the technology feels more like a video game than real life. However, Ramirez says that the loss of hands-on cutting isn't that important of a factor when it comes to these early anatomy courses.
So they will certainly have many other opportunities to touch the bodies. And in addition to anatomy instruction, they are working with, even from the beginning of medical school, working with standardized patients, thinking about physical exam. The vast majority of doctors are not doing open surgeries. So most of them will never need to do that beyond their, the component of their training that every medical student goes through, surgery clerkships, and, maybe some components of residency, depending on what their specialty is. So for those students who will never perform a surgery in their actual practice beyond their basic training, then we're not depriving them of any experiences moving forward.
There are also advanced electives offered where students have a chance to dissect their own cadaver. Instead of a full dissection, they choose one region of the body to fully explore. As with any major changes, there are always unknown variables, like how quickly students adjust or their ability to comprehend the material. Ramirez says that so far there haven't been any noticeable changes in student performance since the shift in 2019. And as other schools slowly start to follow suit, will cadavers eventually become an outdated practice altogether? You can find more information about Kristen Ramirez and all of our guests on our website, radiohealthjournal.org. For more behind the scenes, follow Radio Health Journal on Facebook, Instagram, and X. Our writer-producer is Kristen Farah. Our production manager is Jason Dickey. I'm Greg Johnson.